and unfortunately had continued to have significant disease despite all of them, and again required multiple bursts of steroids on top of these medications because despite all of it, his disease remained active. He had many acute flares of his arthritic disease. He had several episodes of macrophage activation syndrome that required hospitalization and intense treatment. And most importantly, he had progressive lung disease, which was significantly impairing his quality of life and his ability to do any activities. So this is his relevant findings on physical exam. He was extremely small for age, and you can see here his growth chart. He's been off the chart since age 3, likely related to his chronic inflammation and his chronic steroid use. He had digital clubbing, which is a sign of significant lung disease. And he also had significant arthritis that was active despite all of the treatments. Here to the right, I am showing you a picture of, this is an actual picture of his CAT scan. So you can see significant pulmonary involvement throughout, with very terrible pulmonary function tests, as you can see here. Extremely low FEV1 and FEVC, which would qualify him as having severe lung disease. He was noted to desaturate to 84% while performing a 6-minute walk test. Again, a sign of very significant joint disease and very diminished ability to do any functional aspects of his life. Lastly, I want to show you some of his laboratory markers, and this is IL-18. You guys may recall that IL-18 is associated with inflammasome activity and is known to be quite active in patients with systemic JIA. And you can see here all the way down is normal at 500. And you can see that our patient never made it below 20,000. So we're talking about IL-18 levels that are at best 40 times normal. And this is unfortunately something we see fairly commonly in these patients that have severe JIA early in life. And you can see that despite all of the treatments I showed you, his IL-18 was never close to normal. I'm sort of superimposing on this in green his CXCL9 levels. As a reminder, CXCL9 is downstream of interferon, and peaks in CXCL9s, particularly within the context of the high IL-18, are typically seen in his MAS flares. And so these are some of the peaks of CXCL9, which coincide with several of his MAS flares, and again with the high peaks of IL-18 as well. So just to show you significant inflammation, significant macrophage activation syndrome. So yeah, that's in essence the case, which is of course a very, very tough case. And so they were posing to us, should we think about allogeneic transplant for this patient? Which is a very interesting question because SAIA we typically think of as a rheumatological problem, right? But this is a very challenging field, and not only for SJIA, but for many other disorders in rheumatology, because there's 1,000 different ways in which this disease can present. They can do anything at any time for any reason whatsoever. So they can be extremely challenging to treat. So with that in mind, let's talk a little bit about SJIA. We do know that it is an inflammatory disease of childhood. We know that patients typically present with high chronic fevers, rash, lymphadenopathy, organomegaly, and this severe systemic inflammation, which, as I just showed you, is characterized by high levels of IL-18. And that inflammasome activity typically leads to inflammation of other cytokines and the macrophage activation syndrome. I would like to posit to us that this definitely sounds like a hyperinflammatory inborn error of immunity, particularly when we are discussing patients such as this one who present during the first year of life. Um, Treatments for SJA are typically catered towards blocking disinflammatory cytokines, particularly IL-1, although IL-6 and interferon blockade can also be used. But there are some patients that do not respond, and particularly in our experience, patients that present very severe and very early, such as this one, are more likely to not respond. And as I just showed you in our patients, the complications of poor treatment response are many, but include chronic arthritis with disabling function, recurrent macrophage activation syndrome, some of which can have significant morbidity and sometimes mortality, and then of course interstitial lung disease, as in our patient. So as we consider transplant for severe patients with MAS and or SAL or ILD, then we have to try to find the balance, right, between what we consider to be a very chronic disease for which there is perhaps no effective treatment in this particular scenario, but also we have to keep in mind that transplant itself has morbidity and mortality, and it's not something that we want to think about lightly, particularly if we're not sure that it's going to be effective. So in general, when we're thinking about who to consider for transplant, I would posit that there's really two big requirements that we should discuss. The first one is we need to be talking about a genetic disorder, whether we know or not know the genetic defect, but something that we think is genetic that only or predominantly affects hematopoietic derived cells, because again, these are the cells that we are going to be changing with transplant. And so my argument for you here is that at least a portion of these patients have undiscovered monogenic or polygenic causes of disease that primarily or predominantly affect hematopoietic derived immune cells. Why am I saying this? Because SJIA, as I just mentioned to you, is an IL-18 driven disease. This is what drives most of the inflammation, and this is what drives the interferon gamma production that is associated with the MAS episodes. And so there are a lot of other genetic disorders that have been recently described, which I am showing you here in this slide, that are also inflammasome driven and IL-18 driven, most of which cause severe inflammatory episodes that may mimic some of the things that we cause some of the things that we're seeing with this SJIA patients. But also, a lot of these can be amenable to stem cell transplant. Um, and here I am showing you some work from our rheumatology and pulmonology colleagues at Cincinnati Children's. And we see that the lung disease in SGIA is also driven by high levels of IL-18 and interferon gamma. So our colleagues studied bronchoalveolar lavage fluid of our patients with SGIA and ILD and compared them to patients that had pulmonary alveolar proteinosis. And what I am showing you here is that SGIA patients tend to have very high levels of IL-18 and very high levels of the interferon gamma-induced chemokines in their BAL fluid, suggesting that the inflammation in the lungs is driven by some of these. And here I am showing you transcriptional profiling of tissue that we biopsied in these patients with SCIA. And again, this suggests that there is significant activation of interferon gamma and T cell activation pathways, which again leads to think that a lot of this disease is driven by the chronic inflammation and by the IL-18. Would we say that MAS or ILD are caused by hematopoietic-derived immune cells? I would argue that yes. And so therefore, I would argue that considering transplant may ameliorate some of these aspects. This diagram shows you some of the cells that produce the inflammasome activity of IL-18 and IL-1, and you can see that a lot of them are hematopoietic cells and that could therefore be amenable to transplant. All of these can be replaced with transplant, but interestingly, it's not really just those. When we look at patients with fever predominant SJIA or with arthritic SJIA, we know that there's a lot of other cells that are engaged in the pathways associated with the development of these disorders. And a good chunk of them are replaced with allogeneic transplants. So I think looking at the pathophysiology of how this disease happens and what cells are involved leads us to suspect that transplant may be a reasonable alternative. The second thing I always consider is that patients should be at high risk of morbidity and mortality from their disease, right? Transplant, like we were just mentioning, is definitely associated with morbidity and mortality. So it is not something that we would recommend lightly to patients that don't have significant complications from their disease. And I would argue that these patients are very high risk for morbidity and mortality, right? MAS is a very aggressive complication of the disorder that is associated with significant mortality every time it occurs. And here I am showing you data showing the survival of patients with SCIA that developed interstitial lung disease. And you can see that once you are diagnosed with interstitial lung disease, survival for these patients significantly decreases. And if the lung disease is significant enough that you have oxygen, then you see that you really have a sharp drop in mortality in the next 5 years after being diagnosed with this. So again, I would argue that it does indeed have any high mortality. So having this discussion is what actually led us to discuss again transplant for our patients. So returning to our case, we did decide as a group that we wanted to pursue transplant for this patient. So this patient underwent a 9 out of 10 mismatch unrelated donor transplant. You can see here the preparatory regimen that we gave the patient. We did wean most of the other inflammatory medications that he was on, but we kept him on multiple medications to try to reduce that inflammation, including emapalumab and steroids. And this patient is now, 3 years post-transplant. The first thing I want to show you is what happened to his cytokine levels post-transplant. So we are now 2 years post-transplant, and you can see that even despite transplant, it took some time for his counts to normalize, but 2 years post-transplant, his IL-18 is now in the 1600, in the 600 range, I'm sorry. Now, it's still not normal, as you can see. And we'll talk a little bit more about why that is later, but compared to the 20, 60, and even 120,000 that it was before, dramatically better. And his CXCL9 levels are now normal, suggesting that his risk for macrophage activation syndrome is dramatically decreased. This patient is doing great. He's going to school. He's living his best life. He remains off immunosuppression. And most interestingly and importantly, he was able to wean off his oxygen and has no oxygen needs. Is this the case for everybody? So I would like to chat a little bit about what are the outcomes, as far as we know, for outcomes for allogeneic transplant for SJIA. I am showing you here data from the European BMT group from 1996 to 2020. And what I'm showing you is that really during the first 2 decades of life, during the first 2 decades of the 21st century, there was very, very little in terms of transplants done for this group, right? So to the left, you see the total number of auto and allogeneic transplants, and we're talking about single digits for pretty much every year. And then here to the right is allogeneic transplant for all autoimmune diseases. And again, you see that at the first part of the 21st century, we did not do that many, but starting the second decade, it started to pick up, particularly for some of the arthritic complications of disease. Dr. Juliana Silva, who is at Great Ormond Street in the UK, has probably the biggest cohort of patients transplanted for this disease. And she's actually published on the transplant outcomes for patients with severe refractory JIA. She had 16 patients from 5 centers between the years that I write here. Of this, 11 had systemic disease, but you can see here that not all of them had systemic disease. There were 5 patients that had severe polyarticular JIA without the inflammatory manifestations. Now, importantly, all of these patients had been refractory to standard therapy, had MAS, or had failed a prior autologous transplant. So again, we're talking about patients with significant morbidity from their disease and patients that were refractory to our standard therapies. All of these patients underwent reduced intensity conditioning, and all of them had alemtuzumab as part of their preparative regimen. 14 of these patients are alive, so that gives us an overall survival of around 87%. 11 of these 14 patients, so that's 80%, were in complete remission. And by complete remission, I mean that they were not having any of their symptoms and did not need any immunosuppressive therapy to control any of the symptoms compared to prior. Now, is this the same for patients that have interstitial lung disease? And that is a very important question that was just actually very recently published as of last year. So our colleagues, Dr. Matt, Dr. Schuler from Cincinnati Children's led this cohort, and they collected 13 patients, which were treated at 9 different centers across the United States and Europe. The median age of diagnosis of the ILD, again, not just the SGIA, but the actual interstitial lung disease, was 4.8 years, which again suggests to you that this is a very young cohort where the severe disease starts very early in life, and the interstitial lung disease also comes very early in life, although there was a significant variability in the ages, as you can see there. The median age of transplant was 9 years. So again, a very young. Patients, as you may expect, similar to the case that we discussed, had been refractory to a lot of treatments, and the median was 6 different treatments attempted before these patients were considered for transplant. All of them had significant lung disease, and by that I mean they had characteristic chest CT findings, such as the CAT scan that I showed you on our patient. 6 patients did have biopsies, and all of them were consistent with the interstitial lung disease that we see in patients with SGIA. I did not talk a lot about that for the sake of time, but alveolar proteinosis is very common in these patients. All of them present significant interstitial lymphocytic inflammation. There's typically evidence of collagenous fibrosis, and then there is pneumocyte hyperplasia as well. And 5 of these patients required supplemental oxygen prior to being considered for transplant, which again, a marker of very severe lung involvement in these patients. Here I'm showing you the data of their transplant information. So similar to what I showed you in the previous slide, all of these patients underwent reduced intensity or reduced toxicity regimens. Most commonly melphalan and thiotepa based, although there were several treosulfan based regimens as well. And again, The vast majority of these patients received alemtuzumab as part of their preparative regimen. The most commonly used donor was a fully matched donor, as you can see here, though we did have a good amount of mismatched donors as well, including one very heavily mismatched donor here, and one matched sibling. Stem cell source was primarily bone marrow, and the GVHD prophylaxis was primarily calcineurin inhibitor based, although you can see that a couple patients had T cell depletion as part of their regimen. This is the engraftment data. The median neutrophil recovery was day plus 16, so 2.5 weeks post-transplant. The median platelet recovery day was day plus 24. We did have one secondary graft failure, which was around day 32. But for all the remaining patients, the vast majority of them had full myeloid donor chimerism, except for two, and both of them had very high mixed chimerism of over 85% at last follow-up. You can see the dates there. Typical of many of the bone marrow transplants where we use alemtuzumab, T-cell mixed chimerism was common very early on, but only two patients had mixed T-cell chimerism at last follow-up. So again, most of them did develop very high level or full donor T-cell chimerism as well. This is the graft versus host disease and TMA data. So 5 patients developed acute graft versus host disease. 2 of them would what we would describe as minimal disease, grade 1 skin, and 2 of them with either grade 2 skin or gastrointestinal involvement. 1 did have severe graft versus host disease and grade 3 GI. There was no chronic GVHD. Interestingly, there was no lung graft versus host disease. And 2 patients did develop thrombotic microangiopathy, which is, a complication that we can sometimes see in patients that have severe inflammation, such as this one's. Here are the survival curves. So 9 out of 13 patients, or around 70% of patients, survived. Now, this is preliminary data, and I would say not beautiful numbers, but do remember this is something that we did not used to do before and did not consider before. So I would argue that a lot of these patients were extremely ill and extremely sick by the time they were considered for transplant. So 2 of those patients died of CMV pneumonitis and respiratory failure. Unfortunately, viral complications are very commonly seen. 1 patient died of intracranial hemorrhage, and he had a normal platelet count. This was during the COVID-19 pandemic, and it was in the setting of an active COVID-19 infection. So it is very likely that this was associated with the COVID and perhaps part of the hyperinflammatory response associated not only with COVID, but also in patients that have systemic JIA. And then there was 1 patient that had continued progression of lung disease despite the transplant. And this patient died of respiratory causes close to a year post-transplant. But here I'm showing you data of the 9 patients that did survive. All 9 surviving patients did fulfill the definition of a complete response. And similar to what we were discussing before, by complete response, I mean there were no features of their systemic disease. There was no evidence of inflammation significantly enough to cause systemic disease. They did not require any immunosuppressive medication, and they did not have an oxygen requirement. To the right, I am showing you their data of IL-18 and ferritin, and you can see that it takes some time, even 1, 2, and 3 months post-transplant. This patient still had significant highly elevated levels of these inflammatory markers, but they continue to progressively slow down. And by a year post-transplant, we see that they are in a much better place, although again, not fully normal. We've actually seen sometimes it may take 1 year or even 2 years for these inflammatory markers to come to near normal levels. And a little bit more detail about the pulmonary outcomes of these patients. All five surviving patients that required supplemental oxygen prior to the transplant were able to discontinue it, though this did take some time. There was a median of a year post-transplant. And then to the right, I am showing you their comparison pre-transplant and post-transplant pulmonary function test data. And you can see that while nothing was significant, there was a trend towards improvement in both the FVC and FEV1. And we are hopeful that as we gather more data and more patients, we may actually show um, conclusive data that this continues to improve pulmonary function. Although from what I can show you, you see that it definitely improves the oxygen need and the functional capacity of patients. Post-transplant chest CT data was available for 6 patients, and I am showing you some of that here. So 3 patients did show notable improvement in the chest CT findings. So compare the diagrams on the left, which are pre-transplant, to the pictures of the right, which are post-transplant, and you see that there's significant improvement in their findings. And then 2 patients had stable chest CT findings on follow-up imaging. And so this is interesting findings, and I think it has to do a lot with the degree of involvement of lung disease of when we find transplant. And if there is lymphocytic inflammation and disease that we could actually revert, versus if there is already significant pulmonary fibrosis or destruction of the lung, which is, of course, not easily reversible with transplant. And so again, I want to go back to Dr. Silva. Like I mentioned to you, she is at Great Ormond Street in London, and she has the currently biggest cohort of patients with severe refractory JIA being transplanted. Um, and so she has published not only on the first data that I showed you before, but also on what the long-term arthritis risk is for these patients. And so this is from the same cohort that I had shown you from her before. Again, she had 9 centers and 31 patients, and you can see that this one is a little bit of a bigger period when they've been following the patients. And so again, she had the vast majority of patients with systemic JIA, but 7 of these patients had the polyarthritic features of JIA only without the systemic involvement. Again, heavily pre-treated group with 5 median lines of immunosuppression before coming to transplant, and the median age of transplant still being pretty early at 9 years. Of these 24 patients with systemic involvement, 19 had recurrent MAS, whereas 5 had interstitial lung disease. And here you see that the median follow-up is around 6 years. And so in this cohort, she shows pretty good survival at 84%. But interestingly, 9 of these patients relapsed their arthritis. And this was anywhere from 6 months to 10 years post-transplant. And her data shows that this happened regardless of donor chimerism. So we cannot say that this happened only because of mixed chimerism. Also, there was a questionable signal that perhaps the uveitis that can sometimes we see with these patients didn't fully resolve either. Now, this is an interesting question, and it goes back to what I had mentioned to you before. What may be the reason for arthritic relapses? So, recall I showed you, we discussed what are the cells that we are replacing with transplant. And so I do think we are replacing a lot of these cells that have to do with the immune system and that have, of course, a significant and particular involvement of this disease. But I also think there are significant cells inside the joints and that are not replaced with allogeneic transplants. So it may well be that there's reservoirs in these joints of cells that are still causing the inflammation and perhaps the destructive arthritic aspects of the disease. This is, of course, just a theory and something that is being studied at the moment. I think Dr. Silva and team are sort of leading that effort. And they've also published on this tissue resident macrophages, which live through adult life in their joints. So very interesting data. So I do think the question is not fully resolved, but if we can fully resolve all of the manifestations of disease. So Dr. Silva does have an open study of long-term outcomes of these patients, including the relapse risk of arthritis and uveitis. And she is looking for any patients that are over 3 years post-transplant that might be incorporated into the cohort. So I think for very rare diseases like this, it's very important that we all work together. So um, I've been sharing this with some of my colleagues and with you as well. If you have any of these patients, I'm sure Dr. Silva would love to hear about it and to discuss with you. So that reaches to the end of the talk. I hope I have sparked some interesting thoughts for you guys. I would say, in conclusions, allogeneic transplant can induce remission of at least the inflammatory features of systemic JIA, including the ones that are associated with significant morbidity and mortality, such as recurrent macrophage activation syndrome and interstitial lung disease. I think studies are still urgently needed to determine how to best stratify which patients are at highest risk of disease morbidity and mortality for consideration of transplant. I think, unfortunately, we don't have a great way of deciphering which patients are going to be refractory to all these treatments, which patients are going to have the recurrent MAS, or which patients are going to have the severe lung disease. And figuring out how to best do that is going to be extremely helpful so that we can bring these patients to transplant early before the development of some of the severe complications. But as I've shown you, I do think there's a lot of outstanding questions that are still left here. What is the optimal conditioning? What is the optimal graft manipulation? Is it these are patients with significant hyperinflammation. So, what treatments can we do to minimize that inflammation going into transplant? Or what manipulations can we do to the graft to minimize the inflammation that these T cells are going to bring when they come in? Also, the other question is when or how to wean the existing SJIA treatment. As I showed you, most of these patients are going to have gone through 8 or 9 different regimens. Most are going to be steroid dependent, and weaning these in order to be able to do the transplant without them can be a challenge. So I think we're going to need to do some joint studies on how to best do that. Um, Also, as I showed you, the inflammatory markers take a long, long time to resolve post-transplant. That is likely because the macrophages and tissue residing cells take a long time to switch over from host to donor. And so post-transplant flares, particularly in those first few months, may still happen. And I think another important question is how we manage these. Um, Lastly, as I think I showed you, I think the jury is still out on what is the long-term recurrence rates, or what is the risk of long-term recurrence happening. So how do we long-term monitor these patients? How do we make sure that they don't need any more immune suppression? Um, how do we make sure that, we're in essence getting rid of the macrophage activation syndrome and the lymphocytic lung involvement, but also keep making sure that their arthritic diseases is well monitored. So I think this is going to need a long-term rheumatology follow-up. Us transplants and immunology doctors are not as savvy and detecting perhaps low-level involvement of arthritic disease, or perhaps if we are sort of like ameliorating, even if not fully curing the arthritic aspect of the disease. I think that's going to require some joint group together with our rheumatology friends. And then the last thing is also the uveitis. I mentioned to you that there was a questionable signal on this. And so this is also something that's going to require some long-term monitoring for our patients. So with that, I am going to stop there. So we have a few minutes in case you guys have any questions that I could answer. I would like to thank my team at Cincinnati Children's that helped gather a lot of this data. I mentioned Dr. Matt and Dr. Drozdov. Those were some of the main writers for that lung disease paper that I showed to you. Also, a big shout out to our rheumatology team, particularly Dr. Schillert and Dr. Grome, that see most of these patients. A big group to Dr. Silva and the Ghost group, who again have the most follow-up and data on this group and are currently recruiting for long-term follow-up and better studies on this. And then I would love to thank my immunology colleagues, in particular Dr. Rebecca Marsh, who is my main colleague that essentially gathered a lot of this data and this is her patient that I'm presenting, and also several of my colleagues and the transplant team of Children's. And so with that, I will stop and happy to take any questions.
Thank you so much, Dr. Blachy, for this outstanding lecture. Really, you address a highly complex topic, and the advances you're presenting in immune rheumatology and hematology are undoubtedly a bright and inspiring path for our clinical practice. And also, thank you for your collaboration and for contributing to the growth of our community in Latin America. We really appreciate. So, thank you a lot for that. So now it's time for questions. So please feel free to do question to ask for the microphone, or also you can write in the questions and answer chat. Given that we also have rheumatologists in the audience, please feel free to ask anything you will like. I see rheumatology from Buenos Aires, Colombia also. So it's the time.
Remember, could be in Spanish or English.
Sí, cierto. Si tienen con toda libertad, pueden preguntarlo en español, como el doctor lo comentó al inicio también.
Luisa Versa has raised his hand.
Por favor, soliciten que envíen sus preguntas al botón de Q&A que tienen en el menú inferior todos los asistentes de Zoom.
Okay, please send the questions to the special chat for that is question and answers. Alba, ¿hay alguien con la mano levantada en el público? Dice Oscar.
El doctor Luis me parece que bajó su mano. Supongo que estás escribiendo su pregunta en el Q&A. Pero ahorita no tengo a nadie más con mano levantada.
Okay, perfect. So I will start, Blatchy. I'm impressed by the satisfactory outcomes in most of the patients, even though at the time of the transplantation, they had such several impaired pulmonary function. Something that in other settings, for example, could have been considered a contraindication for the
Mm.
transplant. So I'm impressed in that for that point. What do you think about that? And what was the perspective of your pulmonologist team about that?
Yes, I think it's a great question. Because you're right, it's something that had we not discussed as a group, I feel it's something that we could have just said, no, this is a patient that we cannot touch. But our lung doctors sort of brought that data showing that, this inflammatory disease that you're seeing, it's all IL-18 driven, it's all CXCL9 driven. So I think if you can control that inflammation, you can control the the damage to the lungs. And so, sort of parting from that discussion is why we thought that perhaps some of these manifestations would be reversible. Um, but we still don't have a great way of figuring out, um, when we see this severe imaging, like, is this lymphocytic involvement in your lungs, or is this already like lung that is fibrosed and damaged and we cannot bring back? And so I think that is a very relevant question that the lung doctors and us are going to have to figure out together. Because imaging is not great at helping us elucidate that difference. And so we need better ways to do that. But I think what I showed you from the patients is that at least a significant chunk of them will have um, good improvement in their lung status, and even if they're imaging, if we catch them early. So I think that calls for advocating for recurrent imaging of our patients to see if they have lung involvement or not. And so if you start to develop lung disease, even if you don't have some of the most complicated manifestations, right? Even if you don't need oxygen, even if you don't have clothing. I think when you start seeing that those early imaging changes, that's perhaps when we can start discussing about having, what's the best treatment course for this patient. Because if that is happening and you're failing all of your treatments and you still have significant inflammation, then I think that's a patient that we should bring to transplant on the earlier side.
Yes, of course. Thank you. We have a question in the chat. Do you consider the non-related stem cell transplant in this disease?
Yeah, absolutely. So in that cohort I showed you, there was only one matched sibling transplant that we did. The vast majority of patients had unrelated donors. Um, and that brings out another interesting discussion, which is as you guys know, I'm arguing here that these are patients that perhaps have a monogenic or even polygenic disease state that we don't fully know about. And so it begs the question of, when you have somebody in your family, like, what is the risk that somebody related might have some hyperinflammatory component similar to this? I think that's a great question that we don't know the answer to. Usually, we have been using related people. We have been using related donors if they don't show any of the inflammatory manifestations. But I'm a little off topic, but going back to your topic, yes, absolutely, fully match unrelated donors, and in some scenarios, partially mismatch unrelated donors too. Like that case I showed you was a 9 out of 10 matched unrelated donor.
Okay. And what in the case for Apple, for example? Do you have experience for Apple identical in this setting?
We have never done a haploidentical transplant in this setting. Um, I believe that our friends at Gauche at Greater Ormond Street, they They have done some they have that platform of alpha beta depletion, and so I believe that they have done it. We have not as of yet, but we have definitely used significantly mismatched donors, and what we do is we have done T cell depletion, the CD34 selection, and that seems to work okay. So I think if we are sort of forced in a similar scenario of a patient who's not responding to other treatments, I would consider a haplo as well.
Okay, perfect. We have a question in Spanish. ¿Tiene experiencia similar con otras enfermedades reumáticas con involucro pulmonar fuera de las formas de AIJ sistémica?
Ah, buena pregunta. No, honestamente no. Um, but I think the problem with rheumatology is, as we were discussing, there's 100 different things, and they're all caused by 100 different things, and they can present in 100,000 different ways. But I would say, similar to SJIA, if we have a disease where the pathophysiology suggests that the lung involvement is because of cells that I can switch with a hematopoietic transplant, then I think that is something that we could consider. With the caveat of, again, saying these are all very rare diseases, so we definitely have a nice discussion with all of our involved groups before proceeding with something like that.
Okay, perfect. We have other questions. Two questions. Do you think pulmonary biopsy is needed prior to transplant regarding fibrosis? And the second point, can you tell us about macrophagic resident T cells treat prior to transplant?
For your first one, I would argue no. I would say, if you already have significant pulmonary involvement, I would say those are patients that I would just bring to transplant. Now, I would counsel our patients that we may not be able to recover all of the lung function that's already been gone, but I would say that we can prevent further damage from occurring. And I would say this can be similar to our patients with chronic granulomatous disease, that sometimes doing the biopsies can actually cause us a little bit more harm than good, particularly if you have severe involvement. So I don't typically push for it if I know that the outcome is going to be progression unless we do something about it. And then regarding your second question, I think it's a great question. And honestly, we don't know a lot about it. It has been recently described. And part of what the Ghosh team is doing is trying to get some biopsies or even some tissue sampling of joints to try to see what the path is and when or even if these macrophages are going to switch post-transplant. But to be honest, we don't know as of yet.
Okay, perfect. We have more questions. Okay. And it's a thank you very much for the talk. It was extremely interesting. On average, the patients had failed to achieve control despite a large number of therapies. Had any of them used rapamycin prior to the stem cell transplant? In Chile, we have a patient with juvenile idiopathic arthritis and macrophagic syndrome um, and lung disease who didn't respond to tocilizumab or anakinra and is now off oxygen while on rapamycin. It is just a number of one, but it's essentially interesting. And the second question is, why do you think from a pathophysiological standpoint, autologous stem cell transplant has shown success in systemic juvenile idiopathic arthritis? One of the inclusion criteria in Dr. Silva's study was failure of autologous stem cell transplant, or were only the patients with polyarticular that ones who had previously undergone auto stem cell transplant? Very interesting question.
Yeah, that's a great question. So regarding your first question, yes, our rheumatologists definitely have rapamycin or sirolimus as part of their treatments that they use. I will say the vast majority of patients with SJIA we never meet, right? Because thankfully, the vast majority of them are going to respond to one of the many, many treatments that rheumatologists have. So it's really only the ones that have recurrent MAS or ILD, or the ones that have failed a lot of the treatments that our rheumatologists will do, that I meet. So I can't give you an exact number of how many have responded to sirolimus, but I definitely know that our rheumatologists use it and have some patients with good disease control on it. And then as for the second transplant, I think this comes from the adult uh, transplant data. But it's a very interesting question. But a lot of our adult colleagues will do autologous transplants on patients with severe autoimmune disorders. And so I think that is where this approach that the Great Hormones team used. We have not done that. So for our patients, but I will say, I'll be fully honest, we have only dealt with the patients that have the systemic manifestations. So patients with the MAS or the ILD. We have not done transplants for patients that only have the arthritic manifestations of the disease, whereas they have. So I think they have used it in that scenario. For the patients that have systemic disease with the MAS and the ILD, I think you can push. I think in my brain, the pathophys of that suggests that we should go allo rather than just auto. But when you're talking about the arthritic manifestations, then yes, there are some adults that do autologous transplants for that. But again, we have not done that.
Yes, for example, we also have the evidence in adult population for autologous transplantation for systemic sclerosis, for
Right.
example. So we think about what would differentiate this disease from systemic sclerosis in terms of why the evidence supports autologous rather than allogenic transplantation. So maybe different pathophysiology, we don't know so far. And also this supports that maybe this is about genetic disease that we, as you say, that we don't know so far what is the monogenic cause for systemic juvenile idiopathic arthritis. So it's a big field to explore.
Yes, I agree. I would say, a lot of my autologous adult colleagues say that you're sort of like resetting the immune system in a way when you're doing that autologous transplant. Whereas, what we pursue with the allo is more like I know the system is defective and I need to replace it entirely. But I think you're right that there's a lot of this that we don't know because we really haven't been exploring rheumatologic diseases as a reason for transplant until very recently.
Okay, perfect. So we don't have more questions. So Dr. Lachi, thank you a lot for being with us. Always welcome to our community, Latin America. This is your home also. So thank you very
Thank
much
you.
for taking your time. Now we have few announcements to finish our session today. So Alba, do you have the slides? Okay, thank you. So just to say thank you to all the junior community. This is the junior community that is finishing our labor, and this is in Buenos Aires the last October, a wonderful meeting that we have. So I have to say thank you for your work, for your dedication, for your creativity, and for your hard work that have been the heart of so many meaningful initiatives. Your Bull community created opportunities and, of course, left a legacy that we will continue to inspire. So we are deeply grateful for everything you have given. Gracias, Oscar, Rafa from Brazil, that is not here, Mati and Pilar from Argentina. Thank you very much for your work. And now we have to give the opportunity to the next junior community. Our president is Carolina Bozo, I don't know if Carolina is here with us. So Carolina is the new president of the junior committee, and the new members, Gabriel Arce, Luisa Matos, Celina Franco, Nicolás Fraudes, Ivania Miranda. So please be welcome to continue this inspire that we have of juniors community around our region. We have a lot of work to do, and I know that you have all the tools, all the necessary tools to continue with this labor and this commitment. And also we have to remember that we have our official journal for the LACID community, that is the Journal of Human Immunity. Also is the official journal for CIS and also for ESID. So let's publish. And now this is something that you know. So I think that we can finish the session. Thank you, everyone, and have a good afternoon. And thank you, Blachi, again. We hope to have your next talk with us in few time. Thank you very much.
Dale, gracias. Buenas noches.